You're here today. I'm introducing you Dr. Cesar Nomura. He is linking in now from Brazil. He graduated at the University of São Paulo, the place I did my training in radiology, and he is also a PhD from the same place. He specialized in MRI. He has actually spent some time at the MGH as a research fellow on CT and MR of cardiac imaging. He's currently the director of the Department of Radiology at the INCOR. And he's very well known. He's a lot of published articles, at least 62 peer-reviewed articles on cardiac imaging. He's very interested in AI. And his talk today will be touching bases on the implementation of AI algorithms to overcome healthcare disparities in the area of COVID-19. Dr. Nomura, thank you for joining us.
Thank you, Isabel. It's a great pleasure being here. Really, it's an honor for us. This is one of the good things of this COVID-19, or maybe related to those pandemic, that we can connect the different countries, and it's something that used to be more difficult, but now I think it's more common, and so it's a pleasure being here and talking this meeting. So should I start?
Yes, please.
Okay.
And just so, if anybody has questions, we have a QA option. There is also a chat, but we prefer the QA, and I'll bring up your questions at the end.
Okay, so we'll talk a little bit about the use of artificial intelligence to overcome disparities. I'm based in São Paulo, and I'm going to start just talking about a little bit about our institution. So Hospital das Clínicas actually is where Isabel did part of her training here in Brazil. So it is the largest hospital complex in Latin America. So we are 8 institutes, 8 hospital connected, totally with 2,500 bedrooms. We have more than 20,000 employees here. And every year we attend 1.5 million patients in our institution. Also, we have every year around 2,000 students in the medical residency, and we have every year 180 medical students in our institution. We, related to the research and article, 7% of the total research scientific articles in Brazil is related to our institution. Just to give one day, maybe you guys are invited to visit us. So just to give an idea. So here's the cancer center, is 20 floors of just dedicated to the cancer. Here's the Heart Institute, those 2 buildings. Here's the medical school, the central building, or for general areas. Here is where the physician's office in this building. The Children's Hospital, Orthopedic Hospital, Psychiatry Hospital. So this is our institution. Talking about our radiology department, we have 13 MRI scans in our campus. We have running 1 Tesla and also a PET MR. We have 15 CT scanners and 4 PET CTs. In my area of expertise where I stay, so is more related to chest and cardiac. We perform around 3,000 cardiac MR a year, 4,000 coronary CT, close to 50,000 chest CT. 50% of those chest CT are related to patients with cancer or suspicious of cancer. Our innovation center, it's new, so we are new kids on the block. So we just started in 2018. So we are just starting our innovation center. But we have now 70 startups connected to our ecosystem, and we have projects, and there are some important companies connected to us like GE, Siemens, Deloitte, Amazon. We have all others, pharmaceuticals companies also in collaboration to other institutions inside Brazil and outside Brazil. So before I started, really just to give a quick overview from our institution, in in the beginning of last year, when we started, when the COVID started here in Brazil in March, we closed the central hospital, and that is the general hospital, and we transformed the central hospital totally for COVID, and it was a reference from São Paulo state. And basically in the central hospital, we dedicate 300 ICU beds and 600 general beds just for COVID. I don't remember exactly the number of patients that we received in our institution, but until February was more than 10,000 patients, 35% in the ICU for COVID-19. So now really talking about the AI related to the COVID-19. So once when does the pandemic started, we decided to build architecture and to try to help other hospitals and other services in Brazil related, and try to develop some platform with AI algorithm for the diagnosis of COVID-19 related to chest. So this is our partners. So we have different hospitals, including private hospitals, Society of Radiology, that is Paulista Society of Radiology and Brazilian College of Radiology. We have bank, oil companies, and we work together with Amazon, GE, Siemens, and Huawei, and also with the support of Brazilian government. And what exactly it is this project? So the workflow here is, the idea was to offer AI algorithm for the COVID-19 diagnosis related to the chest CT to entire country of Brazil. So basically, what we did was to connect CTs from remote hospitals, and from those hospitals, they connected to our data lake, and from our data lake, we connected to two different algorithms. And the beginning was from Huawei and Siemens, and then at the end, we connected to some startups that were incubated in our innovation center, and also from startups that would like to participate in this project. And then after the analysis of the chest CT, the raw data of the chest CT, so the report that I'm going to show after came with the probability of being COVID-19 and also the lung involvement. The time for this sending the raw data and then receiving back, when the connection and when everything was running, it was around 10 to 15 minutes for the remote hospital receive this information, this report. And this part of this was described in a paper that just came out this month in Radiology, where I explain a little bit about the institution and the project and what we did. And basically, this is part of the report that the remote hospital received, where they receive the possibility of COVID-19 and also the amount of lung involvement. As you can see here, everything inside the green area is part of the quantification. Also, there are other information here about the type of the opacity, sometimes differentiating ground glass opacities from consolidations. In the beginning, we used to have radiologists 24/7 in the first month to trying to help for any doubt related to the report and related to any difficulties with the diagnosis. But after 1 month, we decided to stop with this because it was not necessary. Really was not radiologists 24/7 to help in this case was really not necessary. Just to exemplify how the program works and how they receive it, the images, and they could play and see if it's correct. It's not only receiving the numbers, but also look into that. That is very, very important. I have to say that it's much more important the radiologists seeing the areas and see if he is agree or not with the amount of lung involvement. Even in sometimes in his small areas of ground glass opacities. So algorithms did quite a good job. This is the other algorithm. So we connected, we plugged it in our data lake, 2 different AI algorithms, one from Siemens, another one from Huawei. So they are different. So here, as you can see, there are a lot of data in this quantification. So separate per lobes, upper, right, medium. So per lobes, there are a lot of data related in of course, the probability of being COVID-19 and the percentage of lung involvement here, like is 22%. So again, some quantification, segmentation by lung to know which lobe were involved. So we help it to give a suggestion to those companies. And sometimes we have the bias of research, and maybe we ask a lot of things and they gave to us a lot of data, a lot of numbers. But I will tell at the end of what for me is the most important thing to all of this algorithm. So again, more data showing the number of the score of these opacities and the percentage of lung involvement in this case. And as you can see here, the algorithm is not perfect. Even with a high probability for being COVID-19. So for some reason, the algorithm in this case didn't catch up this ground glass opacity. That this seems to be very, very easy for everyone. But again, it's not perfect, the algorithm. So our platform, so we started in March. In 1 month, we start running this project. And it's important to mention that it was totally free to anyone in Brazil. Anyone who would like, even it's a private or public, could connect it to this platform. At the end of the year, in December, we had 27,000 chest CT analyses through those 2 algorithms and 50 hospitals connected to these systems. We had more private hospitals connected as compared to public. And the majority of the hospitals were in the southeast of Brazil. Just for you to understand, this is the Brazilian map. So southeast of Brazil is this area, the red area, is where São Paulo state it is. You know, São Paulo is the largest population, and so the southeast of Brazil is the in terms of development. So it's richest area in Brazil, in more developed, then followed by the south. And then you know that the green area is the area of the Amazon forest, where we have the most discrepancies related to, well, whatever you think about. So there is a huge discrepancy between the south and the north of Brazil. And we could connect it all different regions to this platform. In some preliminary data from our analysis, and this is one of the things that I would point as the most important. From the first 450 patients, what we found is, here is the percentage of lung involvement, less than 50% or greater than 50%. And when we look to patients with chest CT showing more than 50% lung involvement, so the mortality is significant higher, 36% in this population. So mortality when the patients came in our institution with more than 50% was 36%, as compared to 16% mortality rate when the lung involvement was less than 50%. So also we have more data here. So also when we look to mortality, but also in the intensive care unit, so the number of patients with more than 50% involvement is significantly higher. The need for mechanical ventilation and the length of stay were significantly higher when the patient came with more than 50% lung involvement. And so I think the algorithm, and one of the most important things that we saw was related to the percentage of lung involvement, and not saying if it's positive or negative, not saying if this CT is COVID or no. And one thing interesting that is not here, I think it's not in the presentation, is that we found the typical findings of COVID-19 in chest CT related to the RSNA classification. We saw much more typical findings in the population with less than 50%. And you will say, well, why is the population with less than 50% lung involvement, we saw much more typical findings? Is because probably is related to the timeline of complications related to COVID-19. In patients with more than 50, we saw pleural effusion, a lot of consolidations and other things that really is not the typical for COVID, because it's the evolution of the disease going worse. And we compare radiologists in the machine for the quantification, the lung quantification. And what we saw, as you can see here, like in this case, an example, for the machine quantify as 90%, but both radiologists quantify here the CT as 25 to 50% lung involvement. The other case here is the one radiologist classify as 25 to 50, another one 50 to 75. And the machine came up with the 36%. So we know that the variability in quantification is huge. We know that, of course, if I measure 2 times in the same day, the same CT, I will measure, will come with different numbers. So the most important thing for all those AI that we saw is the quantification of the lung involvement. This is something that the algorithm AI helps. a lot. And when we compare the machine and the radiologist for the chance of that CT being really be a COVID, the correlation was good, was not perfect, but the radiologists, experienced radiologists, still doing better as compared to the machine. And what about AI algorithm in the real world? So I will just show some cases that we faced. As you can see here, when you have emphysema or pneumomediastinal or pneumothorax, so it's impossible to run the algorithm. So it's the algorithm. We try all different vendors. We try different ways. It's impossible also to edit. So it will not work when we have emphysema. Not the case here, as you can see, for some reason, the algorithm think that this area outside of the patients, between the arm and the chest, is lung. There is a tower here, so for some reason. So in this case, the algorithm didn't differentiate what is ground glass opacity from what is consolidation. So showing that the algorithm is really not perfect, or even in this case that there is a previous surgery, there is no left lung here. So, but for the computer, there is always a left lung, so they cannot understand where it is and what is going on. So of course there is a gap from the lab, from the training in from a specific data set to the real world. And the reason that is that the importance of what the machines or what the computer is seeing. And everything what they think it is that will be translate to the algorithm. And this is something what the machine will go show up with a proposition of the percentage of risk or idea. And it's important to understand that the algorithm is not perfect, and someone need to teach, someone need to differentiate what is guacamole or what is a parrot, or what is a chihuahua or what is a muffin. And actually some of them really looks like, right? If you look at those days, I mean, it depends, it's very difficult. But when you look in other perspectives, or you increase and you are teaching what it is, like in this case. So, and the idea is what we would like to understand is what is the difference from really not for everything, not to say that AI works for everything, but we should solve problems. We should dedicate, we should focus in the models. And what is important is to understand if your model is strong or not. Like in this case, the model is perfect to say that it's banana, but once you put something together, it changes the idea, and it's a toaster. So why is it a toaster? For some reason, when you have a very fragile model, so these things can happen, as I show in our with our startups and with the other algorithms of AI. And I would not say the most important thing, but I would say what is very important is the cycle. So the continuous cycle for continue retraining. So the input of data, so there is a prediction, but the physician, the radiologist should continue evaluating and saying that's correct, that's wrong, that's correct, wrong. You know, of course, one time the machine is going to learn, but if you don't continue with all this cycle, so you will have a problem with the algorithm. And everybody know I don't need to explain that prediction is very difficult, but especially about the future. And we have to, we know that this is the data from Gartner from 2018 that less than 50% of the data science projects are fully deployed. And there are many things related to why uh, are not fully deployed. Uh, you can read those articles that it's interesting. Uh, there are problems related to the resistance, internal politics, but there are also manage of data and the way how I implement the AI platform and algorithms. And when we look back to the AI timeline, so it's not new. So this is started in the 60s. Uh, then in the 70s to 80s, we had the first we call the first winter that is related to the limited computer processing power, limited database capacity. So that was one of the problems. But then it came again with neural networks and other new things. And it was the focus was on a specific intelligence. But then in the beginning of the 2000, so again, the second winter with disappointing results. And was maybe related to excessive, a lot of optimistic things, more hypey things. And then I think now we are going to some more mature use of the AI for all areas of the medicine. But we still have some people that sometimes are making some assumptions that it's too early sometimes to say that. I will gonna play a video here. I think all of you know about Jeff Hinton talking about the future of radiology.
Saying a few things that seem obvious. I think if you work as a radiologist, you're like the coyote that's already over the edge of the cliff, but hasn't yet looked down, so doesn't realize there's no ground underneath it. People should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do better than radiologists because it's going to be able to get a lot more experience. It might be 10 years, but we've got plenty of radiologists already. Saying a few things that.
So just to resume, so was a presentation back in 2016, probably when they were facing to a lot of implementation, a lot of interesting things. And he said that in 2016 that we should stop training radiologists. And then another thing is deep learning is going to be better than radiologists. So 5 years, so we are 2021, and so at least in Brazil, and from our experience, we didn't, AI didn't replace radiologists, and we continue training our radiologists here in Brazil. It's something that is very common when we discuss about AI. And those peaks of inflated expectations, right? And then we have the disillusion, and then we apply. So we saw this through many things, and Watson was one of these type of things that happened in the past. I remember first time I remember when they arrived in RSNA, and everybody was talking about Watson. And at that time, it seems that this was going to replace, Watson would replace the physician. but this didn't happen. But I mean, we are not saying that all those things that were developed were not important. It is very important, but we should sometimes be more humble ourselves and really try to go deep in the problems and try to solve the problems and not to give uh, 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 a response to everything. And one of the things that is one of the problems is to adoption of the AI is because AI sometimes is a black box. So you give some number and you came with a result. And as a research, as a physician, it's difficult to accept that you are giving the data and the computer say, so go to surgery, treat with this, so the diagnosis is that. And you are not seeing what is going on inside, right? And one of the problem is because sometimes the neural networks, is also a problem because what I would like to say, if you come with a garbage, you go out with a garbage. So garbage in, garbage out. So this is very important, the quality of the data. And this is the importance of also the radiology participating in all those things. If I have to say one quick thing from all those applications of AI in radiologists that we were faced is the post-processing, image segmentation and quantification. So we can say from all this project that what was more important was the quantification of the percentage of lung involvement. It's not to say that if it's COVID or not COVID. It helps. The percentage of lung helped a lot. And in some cases, the diagnosis of COVID by CT running by the algorithm helps in a remote hospital where we have a general radiologist working like in northeast of Brazil in other area. So in this case, so the AI help to give us support for the general radiologists and to help them to understand that in that case, the percentage of lung is very high and the probability for worst prognosis would happen. So uh, going to the end, I would like to some lessons learned from our experience running this platform in Brazil for the COVID-19 is that the AI algorithm may really increase the accuracy in quantification, but it's to support radiologists and not to replace the radiologists. And the AI helped general radiologists in remote hospital for some tough decisions and to with the amount of lung involvement. And from our project that we offer this, all this technology, all these things totally free, is that with technology, innovation, and collaboration, it's possible to shorten distance, democratize knowledge, and also reduce healthcare costs. Uh, when the academic community, private sector, and government work together, really as a partners, this is possible to do much more with much less. And as a final consideration, radiologists are early adopters of technology, AI tools. So we started a long time ago with a HISPAC system. We started with the telemedicine. We started using all this, it's something familiar to us. And because I strongly believe that radiologists should assume a leadership in the discussion about AI in the real world. The discussion of AI in the real world is not only in the papers, not only in conference, also in the strategic planning of healthcare institutions. Like in global pandemic like COVID-19, this could overcome disparities. Would like also to acknowledge some partners in this project. And with that, I would like to say thank you, and maybe open for question if someone would give any comment. Thank you.
Thank you so much, Dr. Nomura. That was a great presentation, and I think it is very important this day and age to think about the social responsibilities and try to decrease the disparity, because it's very well seen everywhere here as well, the difference between resources and how can that can affect the involvement of COVID. I have a couple questions. So was the institution involved on the training of the algorithm, or they were already established algorithm when you guys start using it?
That is an important point. We started with established algorithms, so we help them to validate with our case. We help them to validate in Brazilian population. But after that, we didn't develop the algorithm. So it's from Siemens and Huawei. It's algorithm from them. We help them to as a machine learning, deep learning, so the cycle that I said, and they made some improvement in the algorithm. The second part was we use all the data sets for the startups, and we opened a competition in Brazil, and we received, I think, more than 20 startups majority from Brazil that would like to connect in our ecosystem. And then we selected 2 startups that the performance of the algorithm were better. And then we connected them, but we are not developing AI algorithms.
But you did validate, so that's good for the population. And when they were submitting cases through the database, you had 2 algorithms in place. How were the cases decided to go one algorithm versus the other? Or they ran through both?
Both. All the cases, they went to both algorithms. And
did you ever correlate them to see? Yeah.
They work pretty well, both. Some difference. Maybe you can ask why both? Because we didn't know which one would be better. And we are in the middle of I would say, battle. And we would like to offer what could be better for the radiologists, and they could decide which one. And the importance is all the data, the radiologists, they had access to the raw data with the quantification to see, well, that's correct. That is, I agree. Right? So, and at that time, we didn't know which one would perform better. So this is why we decided to send both.
So they got a map of the opacities, how the machine got to that conclusion, so they could say, I trust this one more than that one.
Yeah, because radiology, because it's not a black box, right, as I said. So the radiologist really wants to see if he agrees with the amount of ground glass opacity.
Right. Have you, and just as a curious, because we are all still in this pandemic, and it has been going on for a year. So I was curious, have you started seeing complications of COVID, like fibrosis and things like that in Brazil?
Yes, that's a very important point. So we are doing the follow-up of we are doing the follow-up of 1,000 patients from our institution. And we don't know exactly the data, but our impression is we thought that the result would be very, very bad. When we saw the first CT, the second CT, when the patient was in ICU. But interestingly, we are seeing that some of them, they're not going to, not all of them would go to fibrosis. Our first impression is that it's a different disease, different pathology. So when we look like to those horrible chest CT, our guess is that, well, this patient will go for severe fibrosis. And that's what something that we are not seeing here in these preliminary results.
That's good news. Yeah, because they look so extensive and so much abnormalities that you think they will definitely evolve into fibrosis, but not necessarily. That's a good thing, I guess. All right, thank you so much for sharing your knowledge and your experience. It's good to be connected. Thanks to Zoom, we can stay more in touch. I really appreciate you taking the time to come talk to us. Thank you, Dr. Nomura.
Thank you. It's a great pleasure being here. And thank you, Isabel, for the kindly invitation. So it's our pleasure. Hopefully we're going to see in a different moment of of our lives.
Yes.
Thank
Stay
you.
safe, hang in there. Thank you.
Bye. Thank you.
Bye-bye.